Hello. Good afternoon, everyone. Thank you for coming to our panel. We hope other people will continue joining us. My name is Prudence Masako. I'm a country director for CARE International in Tanzania. I'm so pleased to see you. CARE has been to Tanzania for the past 29 years. We came to respond to the Burundi-Rwanda genocide, and then we went to development. Currently, we are into several sectors, health being one of the sectors. We are into climate, food, agriculture, nutrition, education, women economic empowerment, and for us, we believe if people need to really work, they need to have good health as well. So specifically today, we want to share, because we have on our approach of village lending and loan associations, you can call them VICOBA, and we are so pleased CARE is the pioneer of VICOBA in the world, and it's the one who started in Tanzania back in 1994 in Zanzibar. So in everything we do, our approach is through the village and lending associations. So today, you will hear from our very distinguished panelists how the village and lending associations, VICOBA, contribute to the health. And we also hear how best maybe they can have the best alternative of what they get in their groups so that they can have more profound services on health, which maybe are financed and something like that. So without wasting time, thank you so much again for coming. Enjoy, feel at home. You are really at the good place at the right time for the right reasons. And right now, I welcome our moderator today, Dr. Harry, who is the country director for Pharmaxis. Thank you so much for agreeing to come and support us and moderate this. I know it's at the heart of what you do, so really stay tuned. And yes, over to you, Harry.
Thank you, Prudence. I prefer to stand here at the podium. Is it afternoon already? Good afternoon, everyone. It's my pleasure to have this opportunity to lead this session. And I understand I have very reputable panelists who will join me in a few minutes. But before I call them on stage, I want to reflect some few things. Is there anyone who don't understand Kiswahili? Is there anyone who don't understand Kiswahili? But sometimes I find it strange to speak in a foreign language while all of us understand Kiswahili. So I'll be mixing both. So why are we here? So if you look, since we established health financing through health insurance in Tanzania, it's more than 20 years now. But yet we have less than 15% of people who can access healthcare services through health insurance. In fact, in a recent health expenditure study, which has not yet been released, but I have the data, the out-of-pocket expenditure is increasing and now has reached, is it 29% or something, which definitely tell you that there are people who are pushed into poverty because of healthcare expenditure. Why? Because obviously, if you are using more than 10% of your income for healthcare, then you are in trouble. So why we have those disturbing facts? There are some promising results come from a study which was done to these village saving and loan association groups. One of the interesting findings was that out of these members of the VSLA, these VICOBA groups, 60% of them have sought financial aid for health services. Not only that, 81% obtained support from VSLA group, they were utilizing 41% from the total social fund. It is unfortunately that among the members of the groups, na sio wachache, if I look at the members which are now under these groups organized by CARE, they are more than 1% of Tanzanians. And yet only 10% of them have health insurance. What is interesting, however, we see that out of those who are insured, 68% had to get loan from VSLA, from these loans facilities, ili waweze kujilipia bima. So, at least for me, I have 3 learnings from this study. Moja, cost of care is a big challenge. As I said, as shown in this study which I just mentioned, the total health expenditure, but you also see it here. 60% ya member ilibidi wakakope ili waweze kutibiwa. Unaona? So it's a challenge. So that means they cannot afford to take care of their own care. But second, we hear from this study kwamba majority with insurance has to get loan to pay for premium. Maana yake ni nini? So the second finding, or the second lesson from this study to me, people are struggling to pay insurance premium. It is strange in Tanzania, and this applies for both private and public insurance. Those who are employed are paying premium monthly, 3% ya mshahara kila mwezi. Lakini mwenzangu na mie ambao anaingiza income yake on daily basis, anatakiwa alipe annual premium. So tunaona hapa wengi wana struggle kulipa, kwa hiyo inabidi wakachukue mkopo ili waweze kulipa. But the third lesson from me, from this study, the willingness to pay for health insurance is there. We just have to come with the right product, right price, and reach them at the right time or convenient time for them to get enrolled, because the willingness is there. So to discuss those questions, I have a team of panelists, very senior in our health systems. So please allow me to call them in front. So I will start with Christine John. Christina John is a senior fundraise manager from CARE. Please welcome. Panelist wangu wa pili ni Jeronima Tarimo. Jeronima yeye ni mshiriki na mkufunzi wa hivi vikundi. Karibu Jeronima. Watatu, a long-time friend and a brother, Dr. Ntuli Kapologwe. Dr. Ntuli is a director, health, social welfare and nutrition services at PORAG. Wanne, again, another friend of mine, Hippolyte Lelo. Hippolyte is a marketing and customer service manager at NHIF. And my teacher, my senior, Dr. Makwani Ahmed, who is a director, Division of Reproductive, Maternal and Child Health Services. So, welcome. Karibuni sana. So I'll start with Christine. VSLA, I think country director ametuambia the history, a short of it. So can you tell us how they are organized and how big the community is and where are they located, the groups are located?
Okay, thank you, Dr. Harry. So as Prudence mentioned, CARE International has been working since 1945, and VSLA, or Village Saving and Loan Association, is one of our key approaches that we have been using. So in all our programming, as Prudence mentioned, we are in climate change, food, water, and nutrition, but also gender equality, health, etc., etc. So we use Village Saving and Loan Association as an entry point because our impact group is marginalized community. So we have been working with women and girls, and as she mentioned, we put women and girls at the center of our work because we believe that we can't fight or achieve social justice or eradicate poverty without making sure that women and girls have equal opportunities and also human rights. So just to mention, Village Saving and Loan Association, as I said, is a self-managed group that is formed between 15 to 30 members, and most of the time, because we put women and girls at the center, we always say that we want to see within those 15 to 30 members, at least 70% are women. Because as I mentioned, women has been lacking some of the opportunities within the community, especially because of the culture or social norms. So, healthcare, we have a standard Village Saving and Loan Association methodology that we have been using. So you'll see that when we organize those groups, we have to ensure that we follow that kind of methodology. So we mobilize those groups, and we're not only working alone as care, but we work closely with the community development department, because they're the ones at the government level who are managing such kind of groups within the Tanzania, etc., etc. So we work closely with them to make sure that we organize them, but using our standard VSLA methodology. And at the end of the day, when the group is already formed, we train them using the VSLA methodology. So within that VSLA methodology, we have like 80 modules that those kind of a group has to pass. And you'll see that they have to go at least 52 weeks. So that is 12 months. So within 12 months, we make sure that we train all of those groups around those 80 modules. So from leadership and election, they have to learn on that, but also they have to learn also how to organize or to conduct their weekly meeting, but you also how to also buy share. You have also to train them on how best they have to do those purchase of sharing, but you also, when they reach at 3 months, it's the time where they can start taking loans. So you have also to train them how they're supposed to take loan, and when they repay back the loan, how are they going to keep the record so that they continue to be effectively managed. So within those kind of groups, and I mentioned that we are working with the marginalized community, so we emphasize them at least to buy maximum of 5 shares per week. So it depends on the context specific, so you find that 1 share can be 1,000. So if it's 1,000, if it's 5 shares that they have to buy per week, it could be 5,000 per week. So it depends. I can buy 2 shares, depending on how much I have in that particular week, but someone can also buy 5 shares. So within that group, there is specific for buying share, that is particular for saving, but also they have the social fund, which is also very critical for the discussions that we will be having today. So the social fund specific is to help the group when they get some emergency. So if a member of that particular group has an emergency, they can take some amount from the social fund and also provide to that particular member. So those is how, just in summary, it's how the groups are organized. But for us as care, as Prudence mentioned, we have like 29 years working in Tanzania. So we have managed to mobilize and establish a total of 30 million groups across the country. Because we have been working almost across the country, but currently we are working almost in 11 regions. So we have more than 30,000 groups that we have been working, and within that group, we have more than 700,000 members, and 77% are women within those groups. And they have also managed to save almost 64 billion Tanzania shillings since we started. Yeah, thank you.
Thanks Christine. Tusikie sasa kwa mhusika mwenyewe. Jeronimo, Christine ameongelea hapo kuna social fund, na wewe ni mnufaika lakini pia ni mwalimu. Utayari wa wana vikundi ukoje kwenye kujiunga na bima ya afya?
Asante. Habari za mchana. Kama alivyosema mwezeshaji, naitwa Jerome Ahmed Tarimo, ni mnufaika lakini pia ni mwalimu mwezeshaji wa hivi vikundi ambavyo dada amevielezea kwa undani. Nilianza kujiunga na vikundi kama mwanachama mwaka 2009 katika mradi wa ongeza akiba. Baadaye nimetekeleza miradi mbalimbali ya shirika la CARE, takriban miradi 6-7 hivi kama mwanachama, lakini baadaye nilipata fursa ya kupata nafasi ya kupata mafunzo kama mwezeshaji wa vikundi. Na baada ya kupata mafunzo nimekuwa mwezeshaji, na yale ambayo ameeleza dada hapa basi mimi ndo natekeleza kwenye hivyo vikundi kama sehemu kama mwalimu. Kwa namna kipekee vikundi hivi na fursa ya kuweza kufanya hivi kujiunga na bima ya afya kwa sababu kwanza wanayo michango mbalimbali, mchango wa afya wanaita mchango wa jamii, ambayo ule mchango kazi yake ni kusaidiana kwenye vikundi. Pale ambapo mwanachama amefiwa au anaumwa, kazi ya ule mchango kazi yake kusaidiana, ambao unaitwa mfuko wa jamii. Ule mfuko wa jamii umekuwa ukifanya kazi hizo mara zote. Lakini mimi kama mwalimu, kwa sababu nimefanya kazi kwenye miradi mingi, tulishafanya kazi na NHIF katika mradi wa kikoa. Walikuja katika vikundi wakatoa elimu, wanachama wakahamasika na wakawa wanachanga shilingi 70,000 kwa ajili ya kuweza kujiunga na bima ya afya. Katika eneo ambalo nilihusika sana hasa mkoa wa Morogoro, zaidi ya vikundi 25 niliviunganisha na huo mpango wa kikoa, na walikuwa zaidi ya wanachama 225 walikuwa wanufaika kwenye huo mpango, na walichanga bila shida kabisa kwa sababu fedha wanayo kwenye vikundi. Na baadaye NHIF wenyewe walisitisha ile huduma, lakini wanachama walikuwa tayari walijiunga kabisa wa vishindo. Na naona kama katika kipindi hicho ambacho tunaunganisha wanachama takriban katika hao 225 180 walikuwa wanawake na kama 45 wanaume. Kwa hiyo mwamko ni mkubwa na uwezo wanao kwa sababu kwenye vikundi hivi fedha tayari wanayo.
Asante sana. Nafikiri umetoa mfano mzuri. Labda utuambie kidogo 70,000, 74,000, 78,000 walikuwa wanaichangaje? Kwa kidogo kidogo au wanaichanga mara moja na wanalipa yote kwa wakati mmoja?
Asante. Katika vikundi hivi kama nilivyosema, kwanza kuna mifuko aina mbili. Mfuko wa kwanza ni ule ambao wanaweka akiba share zao, ambayo kwa wiki wanaweza kaweka hisa 1, 2, 3, 4 au 5. Lakini mfuko mwingine ni mfuko wa jamii ambao kila wanapokutana kwa wiki huchangia mara moja. Mfuko huu mara nyingi hautumiki, unakuwa upo tu katika kikundi. Unatumika tu pale ambapo kunakuwa na majanga, mwanachama anaugua ama amefariki kwa ajili ya kumpa pole. Baada ya kuwa na hiyo bima ambayo nimezungumza ambayo tulishawahi kutumia, tuliona kama kuna sehemu nyingine ya kuutumia ule mfuko, na wanachama waliamua kuutoa ule mfuko kuwezesha wanachama kuwa na bima. Kwa hiyo kadi ambavyo walikuwa nawezesha kutokana na ule mfuko ulivyokuwa umetuna. Kwa mfano kama kuna baadhi ya kikundi kimoja ambacho wenyewe ulivyokuja huu mpango walikuwa 18 na wote walikuwa na fedha kwa ajili ya kuilipia hiyo bima kwa wote. Kwa hiyo inategemea na ukubwa wa mfuko, lakini baadhi ya vikundi waliwezesha na vingine waliwezesha awamu kwa awamu.
Asante sana. Labda tuende kwa Lelo. Lelo, you heard from Tarimo. Very clear example. They sensitized and people joined just for you to let them down by stop the services. What was the challenge? Let's start there.
Okay, nashukuru ametoa mfano wa kikoa. Challenge sasa nije namjibu yeye pia kwamba aielewe kwamba the health insurance ili iweze kufanyika vizuri ni lazima inategemea numbers, watu wengi. Katika kanuni mojawapo ya kanuni ni kuwa na sheria ya watu wengi, kwa sababu wakijiunga wachache katika kikundi cha watu wengi ni kwamba kuna compromise, kuna hatarisha uhai wa mfuko. Na kwa maana hiyo nikichukua mfano wa kikoa alivyokuwa anakitamka, tulikianzisha mwaka 2013. Tulikuwa tunachaji shilingi 76,800 na kikundi kilitakiwa kuwa na watu 100 na kuendelea. Na tumepewa impressive statistics hapa kwamba watu walikuwa wako wengi kwenye VSLAs, lakini sasa watu wanaojiunga, mwenyewe umeona ametamka watu 225, lakini kwa numbers zilikuwa tumetajwa hapa, unaona ni kama 0.00 nyingi kabla hujakuta namba. Kwa hiyo inaonesha vitu viwili. Moja ni kwamba watu ambao wanahitaji tu huduma za matibabu ndio wanajiunga na bima. Kwa hiyo katika watu probably 10,000 wanaweza kujiunga watu 225, na hawa ukiangalia vizuri asilimia mpaka 70 hawa tayari wanaishu, na mostly unakuta ni chronic illnesses ambao utakuta anahitaji kufanya dialysis au anti-cancer drugs ambao zinatugharimu. Kwa hiyo mtu atajiunga kwa 76,800, kwenye kikundi kwenyewe hawezi kufanya subsidization, yani ule mchango wao hawatoshi hata wenyewe kucompensate. Kwa hiyo ilikuwa sababu mojawapo kwamba hii inaleta adverse selection. Lakini cha pili, kulikuwa na watu ambao wanaenda kufuata vile vikundi, kwamba mimi pengine sihitaji vile vikundi, lakini nahitaji huduma ya matibabu. Kwa hiyo nitakachofanya, nitaenda kujiunga kwenye ile kikundi ili niweze kupata ile benefit ambazo zinatokana na kile kikundi. Kwa maana hiyo, kirani utilization unakuta imeshavuka the allowed rate ya 75%, inaenda mpaka 400%, kwamba kila shilingi 100 unayochukua unatumia shilingi 400 kumtibia mtu. Kwa hiyo tulikuwa hatuna option mbali na kusitisha utaratibu ule. Kwa hiyo ni kitu kizuri, kilikuwa tumeanza kwa nia nzuri kabisa na tukaweka control za kutosha, lakini bado kulikuwa na namna ambavyo sisi watu kwenye vikundi wenyewe tunaleta wageni ambao wanatupa kiingilio, mitaji, mwisho wa siku wananufaika na ile fao la bima ya afya, ambalo unakuta mtu mwenyewe kikundi kiko Morogoro, yeye yuko Dar es Salaam, ana operate kutokea Dar es Salaam, anatibiwa na kikundi kilichoko Morogoro, mfano tu. Kwa hiyo hiyo ilikuwa ina compromise sustainability ya mfuko, kwa hiyo tukasitisha. Lakini hatujafunga milango, tuko wazi. Tunajua sheria ya bima afya ilisharekebishwa na inaruhusu mtu yeyote kujiunga na mfuko. Tumeanzisha utaratibu wa vifurushi, ambapo mtu mmoja au yeye na familia yake anaweza kujiunga kwa kuchangia kwa mkupuo ama kwa kulipa kidogo kidogo, kwa utaratibu unaitwa dunduliza. Kwa hiyo ilikuwa ni kwa staili hiyo, lakini sasa tumekuja na solution nyingine ambayo tunadhani kwamba itamwezesha mtu yote bila kujua kwamba kwenye kikundi au hayuko kwenye kikundi kuweza kujiunga.
Asante. If I can ask again, is there anyone who cannot follow Kiswahili? Okay, so we have few. So I'll come back to you on that issue. But now I'll go to Dr. Ntuli from PORAG. I understand that you are a big advocate for primary health care and UHC. And I also know that PORAG has played a big role in the establishment of the improved CHF, which so far has covered about 5% of the population. And I acknowledge the presence of Dr. Boniface, who happened to be one of the coordinators for ICHF. So are there opportunities from the UHC which you see from this kind of groups, the economic empowerment groups?
Yeah, indeed, there are a lot of opportunities. You know, any insurance works on the solidarity principles, and this is just to allude to what my colleagues have said, but what we can encourage these VSLAs to make sure that they encourage others to join so that they can have a big number, so that from there then there can be risk pooling. and of course the financial pooling. So looking into the pillars of financing, starting with the revenues, then going into pooling, where you can have cross-subsidization of risks and finances, together with purchasing services. All these groups fits into all those three pillars. So what I think is that we need to formalize these groups in different areas, not just VSLAs. We have a number of groups which are not formalized, so that they can have the leadership structure, they can have the best way where they can be tracked through, and from there then we can use them to be able to help us out. As per primary health care, we're looking into the values. The community orientation is key. Then looking into affordability of services is another value. So this is one of the things which I gotten from listening from my colleagues who presented, and of course the beneficiary, that this is an opportunity where we can tap into. With the improved community health fund, we were able to find out this type of groups, and they helped us to enroll into community health funding. And in so doing, we increased the enrollment rate. So these type of groups should always be encouraged, and we as the service providers will help us also to inculcate the culture, because in the end our vehicle to universal health coverage is universal health insurance. So how do we make Tanzanians have that culture to pay for services? This should be one of the things to be encouraged with. So for me, I was so much amazed to hear from the presenter, my colleague here, Christina and Jerome, and I find it as an opportunity where people, they can slowly, because in the end, for us to achieve universal health coverage, we need mandatory health insurance. But to reach to that point, you have to make sure that people are ready to pay. The willingness to pay should be always there. So Marwa, I find this is something which we should always work together so that we can be able to achieve health for all.
Thanks. Before I go to Dr. Makwani, so again to Ntuli and probably to Lelo, do you think we have put enough incentive for such groups or even low-income earners to join in our insurance schemes? Because I've been hearing since yesterday people are talking of there is no willingness, people don't want to join. Do you think we have put the incentive for them to join?
I would say to some extent yes, but still we have some work to do. Still there's a lot of fragmentation in that area. We tried initially, it was 1994, when we were at that old CHF, but as CHF evolved, then we reached out to these different groups, but still I think we need to formalize it. This is a huge opportunity, even if there are 200, but if you have maybe 13,000 of 200 people, it will be a different number, and there will be risk pooling there, and we'll avoid adverse selection. Because in the end, what we want is to avoid the adverse selection. And these type of groups, they offer that opportunity to avoid. So to respond to you, I think we need to work on it. But to me, this is a huge, huge opportunity. You can reach out to them easily. You can educate them. But above all, they will have that culture of actually paying for services, which is the most important thing.
And Lelo, can you answer the same question? Have we put enough incentive for these kind of groups or low-income earners to join into our insurance packages, or we are just complaining while we have not put enough incentive? I'm saying we because I'm also involved.
Sure. Yes and no. We'll start with yes. We have done our part, but not that much. which qualifies for a no at the end. But for example, for National Health Insurance Fund, we introduced these packages which I recently mentioned, Vifurushi, following the discontinuation of several products which were initially introduced, like Ushirika Afya for farmers. We tried our level best to go to all those regions where we have cash crop growers, and we ask them to contribute 76,800 per year to get treatment from the primary level facilities to tertiary facilities. But out of 200, let's say 200,000 farmers in Twara and Lindi, only 500 farmers agreed to register to the fund. So I think you can see even the cost of sensitization, cost of design, cost of registration is much bigger than the cost, the premium which we received, leave alone the consumption, the utilization which we incurred while we paid their claims. So we designed interventions which they could use to enroll to the fund. But unfortunately, we find it challenging when only those who are in need of medical attention are enrolling to the fund at that time. So they are aware that we need insurance. They are aware that there is ICHF, there is NHIF. They are aware there are certified facilities around. They are aware there is an enhanced benefit package. They are aware the premium is relatively low compared to the formal sector. But at the end of the day, somebody have competing, they have competing priorities. Health will come last. What will move somebody to go to procure health insurance is when they find they have a huge medical bill. So they find the alternative, they have to go to NHIF to register and access medical. So partly we have done our part. But the second part, that is not much. Our traction at the bottom of the pyramid for those people in the informal sector, not that much. We have left this to our brothers at AMISEMI, much to them. So we are also struggling to go down there at the bottom of the pyramid. As they say, wealth is at the bottom of the pyramid. To design maybe packages, geographical packages. Maybe somebody don't want to go to Muhimbili, tertiary facility. Somebody want to go up to Masasi District Hospital only. So maybe they need to enroll to NHIF. So we are missing something like that. So yes and no.
Yeah, that's a very important point, I think, especially the issue of the right package. Just to share one example before I move to Dr. Makwani. Recently, a relative of mine was going to a college in South Africa, and he managed to enroll into insurance scheme while here. He paid the annual fee, and then he had coverage for the whole year. And normally, because it happened when he was here, so normally the renewal is when he was again during holiday here. Well, the renewal also happened when he's here. Tarimo, if you group yako iliyoko Mahenge wakitaka kujiunga labda wakati huo na NHIF, walikuwa wanaweza kujiunga wakiwa Mahenge?
Kwa wakati huo hapana, ilikuwa ni kujaza fomu, kisha fomu zinakwenda kwenye ofisi ya NHIF, wanasajiliwa. Wakati huo ilikuwa hawezi kujiunga online.
Don't we think even our processes discourage people to join insurance?
For example, these VSLAs, we needed them to maybe to register the area of operation. For example, and that's for control purposes. If Lelo is in Dar es Salaam and is subscribing to a group which is in Mahenge, now you know Lelo is not a member of that group. That group maybe it's an economic group for people who are in Mahenge. And has been identified by CARE, for example, CARE, and is receiving maybe technical and financial assistance from CARE. But Lelo is a trader, is in Dar es Salaam, maybe has 2 hardware shops, earning more than $1 million in a month. but he wanted to subscribe to health insurance at 76,000 together with somebody in Mahenge who maybe is not earning that much. So that's why we restricted that the registration should be at the regional level. Now, it is not necessary, maybe even if we have traveled to go to an NHIF office. We have online member registration where the group leader can enroll by accessing our portal, can enroll all members of the group at once and get a control number and make payment. We are also thinking of partnering with the NIDA. Of course, we are somewhere where we can use the identification number. Instead of printing cards, so that somebody from Kazuramimba needed to travel to Kigoma town to collect his or their medical card or to register, can just use the national identification number, go to the certified facility and access medical services. So in terms of processes, we have tried to simplify them, and soon we are going to do away with the NHIF medical cards. We are going to use either mobile number or national identification number. By the way, you know, every mobile number is layered under national identification number. So using national identification number will be the solution for those people who are 18 and above. We are also thinking of biometric enrollment for those dependents who are below 18 years. So in terms of processes, we are not that lagging behind. We have tried our level-based, and we think in a year or so, we are going to use the national identification number as a solution.
Thank you very much. Now I go to Dr. Ahmed Makwani. Doctor, your department, let me put it that way. I think 60 to 70% of users of healthcare facilities are women and children. And you are leading the department which oversees health services for women and children. But you are also representing ministry at this panel. So how will the ministry leverage available opportunities to achieve the UHC?
First and foremost, we should understand that the core function for the Ministry of Health is setting the standards, putting in place some policies that enable the provision and the use of health services in the country. So, first of all, I'll look this question into a policy level. When you examine our policy, a leading policy in that case, when you look at the health sector strategic plan, I won't refer to the National Health Policy because it was made in 2007. You find that there are some marginalized groups that needs to be taken care of. And also we put the issue of having universal health coverage as a key of ensuring equity in the provision of health services in the country. But when we go to the regional level, East African community is in a marathon to try to make sure every country, its citizens have been enrolled to universal health insurance. So we are competing. A common person in the suite would not understand this. But at policy level, we know we are competing with Rwanda, we are competing with Kenya, we are competing with Uganda, and that's why you can hear Rwanda, they announce, we've insured our people. Kenya, they announce, we've insured our people. In Tanzania, we are struggling with our legislation for universal health coverage. This is a competition within the region, which is driving us. And it states very clearly that the insurance we want, it should be portable. That means if you are insured here in Tanzania, it will be possible for you, if you go in Kenya and you fall sick, to get treated without paying. Those are issues of when you look at a policy level. But when you come to how to practice it, the first thing here is to have an instrument. And that's why you can hear the health insurance bill, which we are now trying to struggle to make sure by November at least it gets tabled in the next parliament for reading. So all these are pieces of policy which we need to explore. And any country that has ensured its people, that's where you start. Those are the building blocks that you need to put. Secondly, there are issues of financing the bill, making sure the law you are having, it is getting financed on the ground. That is a most difficult area, and Dr. Ntuli got a PhD in that area. It is a most difficult area to explore. And you have heard my colleague on my right side, and Dr. Ntuli, and our colleagues from CARE. They were struggling between financing the health insurance. That is, I think, the most difficult. I would say one of the questions that needs to be answered currently is how are we going to ensure our people? How are we going to make sure that the act is really working when it is acted? The first thing, we have low-lying fruits. Workers, we are the low-lying fruits. We don't choose to be deducted to finance the insurance. We are the culprit all the time. But the second group are business people. Business people. How much are we able to reach the businessmen? It's not surprising somebody in Kariako who is earning maybe 2 million a day there has no insurance. But this is the first person who complains when he goes to Muimbili if he falls sick and he stays there for 1 month. He's the first person who is complaining that the price is too high to afford. Why you didn't get an insurance while you were earning 2 million a day is a question that needs to be answered. Is another PhD that we need to put on top of Ntuli's PhD. So those are the questions I think we needed to answer. But I was born from a family of farmers, a peasant, I would say. And my holidays I spent with peasants. Last holiday I was in the village. And before that holiday, I went to when I went to the village, there was my schoolmate. I told him, George, you have tractors, you have mikorosho here. Why can't you think to ensure your family through the NHIF? You were saying, Makwani is very expensive. I told you, yes, but I tell you, the day when you fall sick, that's when you see the value of your insurance. I said, let me try. Fortunately, he tried and insured himself. Mungu angali, lazima kufundishe. After several months of persevering with very good health, he got sick. And he went as far as Ndanda designated a regional referral hospital. So when I went to this current holiday, he was giving me a testimony. He said, Makwani, you helped me. I said, what? When I looked at the bill, if I were to pay from my pocket, it was a lot. So how much do we explore from this person who had an insurance, not because he was sick, he was okay. He got an insurance, and later on he got sick, and the insurance helped. Those testimonies are very strong in terms of making sure the community can buy in the insurance. That is one example. But how much he has talked about these small corporates, farmers corporates, ushirika ule wanaofanya. When I was talking to my colleague outside there, I told him that, when I went to Mangaka for my holiday, one of the questions was, farmers had paid their corporate some amount of money, each of them, hoping that they will get Bima ya Afya, because previously they were able to get it. But then there were some changes, they were unable to get the bima ya afya. So from a person from a ministry, they thought I'm the one who is owning the bima ya afya. So all the questions came to me, and they were at my door all the time trying to answer. And fortunately, I managed to call your director, and he tried to explain what was the process. But you can imagine now there is a refund. They were to be refunded. So this is an area that I see another opportunity that we can get. The other opportunity is how much do we explore from taxes we pay. Kila siku tunanunua vitu, tunanunua chumvi, hatutaki risiti. If at all we want the government to subsidy to that small marginalized group, we need to make sure that we get those tax points. Every time you don't get a receipt for the tax, you make the government lose a lot of money, to be sincere. What incentive do we put to the people when they go for their shopping to make sure they get those income tax receipts? And what mechanism do we put ensuring that the tax that is collected, those points can be a dividend towards making sure a person who has received those points at certain level can accrue maybe the bima ya afya. Those are some of the opportunities that I see we can try to leverage. Again, in our country, we have potential of natural resources. How much leverage can we put to those natural resources to make sure they can contribute into our insurance? And then, when the act comes, what would be the fate for ICHF? For me, I look at it as an opportunity. Actually, I was teasing him. Calculate if every Tanzanian was contributing 10,000, which is our dominant currency currently, 10,000 per head. And if they contribute 10,000 per total population, how much are we gaining from that? And that can contribute somehow to the health insurance, because here we are talking about the pool. So those are some of the areas that I see if we examine it very well, and if somebody else can get another PhD like Dr. Mtuli, can assist us to answer those questions. I submit, sir.
Thank you very much. I guess probably some audience members who are doing PhD will also be able to assist us. But before I open the floor for questions, you have mentioned one very important thing, how to finance the bill. And obviously, you mentioned some low-hanging fruit, which I completely agree with you. In that area of low-hanging fruit, I look at one area, which is maternal care. Already, government is subsidizing maternal care. And speaking of insurance, you actually refer to demand-side financing. So do you see as an opportunity to use the money which currently we finance maternal care through supply side, and we turn it through demand side, so that the money go through NHIF, and women who are pregnant get NHIF card with a package specific for pregnancy, so that we can increase efficiency, we can increase accountability. Lelo can tell you how insurance increases accountability, and also empower these women to look for the better care. Do you see that also as one of the low-hanging fruit? Maybe you can answer that, and then Tuli might want to add that.
This guy is resurrecting some of the lying issues. In maternal and child health, again another question which is emanating from that. Because Sera ya Afya, National Health Policy of 2007, it puts very clear that kuna baadhi ya makundi some of the groups, and these are women and children, women in pregnancy and children, should receive their services without charge. Sio bure, without charge. There's a difference between bure bila malipo. These women are receiving services without charge, but not free of charge. There's somebody else who is footing their bill. Who is that person? We buy commodities using budget financing, but we also get commodities from our partners. We buy commodities from national budget, but plenty of it, we get it through ARV, for example, from our partners. These are not bure. Somebody's charging. So you can't just say, send this man this side, it will help to curtail these challenges. Because somebody else is like an assurance, to be sincere. And we did that in Southern Highland, we did it in Mtwara with the GIZ, whereby women were insured through the National Health Insurance. So that is a very gray area that again needs to be examined very, very carefully and critically before making an answer yes or no. By the way, despite of that subsidy, bado baadhi ya kina mama wanaenda vituoni, unakuta kwamba gloves hazitoshi, kitu fulani hakitoshi, there's no this medicine, somehow they need to go to the nearby pharmacies, they buy. And I can give you one example. I was in one of the districts somewhere here in Tanzania. So we went bush.
Doctor, if you can finish in 1 minute.
Yes. And we met a laboring mother there. And you know these midwives who have come from big hospitals. So they were examining according to the protocols. By the time we were about to leave, the facility had no gloves. So I had to go to a nearby shop. These small pharmacies, nikanunua gloves zote zilizokuwa kwenye pharmacy nikazileta pale kwenye. Kwa hiyo mambo sio rahisi kama tunavyoyaangalia. We are struggling a lot kule juu kuhakikisha mambo yawe smooth. I submit.
Dr. Antuli, 2 minutes if you want to.
Yeah, thank you very much. And maybe to add on what my brother Makovani said, to me, I think the vehicle to the promised land is universal insurance, mandatory insurance. Because, you know, some of the things are seasonal, including the pregnancy. It's not permanent. You'll be pregnant, you'll deliver, then maybe you spend 2 or 3 years, then you become pregnant again, you see? But if you have the universal insurance, all these challenges will be taken care of. That's why I was in support of the village savings and loan associations, because they are targeting the poor. So there's a component of economic empowerment, but at the same time, there's this solidarity mechanism, which is what the insurance is all about. It needs to have risk pooling, where you cross-size the risks vertically and horizontally. In so doing, then you take care. So I think maybe to emphasize to what my brother said, how best do we finance the bill after being passed? That will be one of the huge challenges. That's why in one of the talks, I was calling for the partners, both international, local, to join hands with the government, to work with us, to see how do we make this bill take off after being passed in the House of Representatives. That is going to be a huge undertaking, and it will need us all to work together so that to push that agenda forward. We need private sector. We need non-state actors. We need the influential, non-influential, bilateral, multilateral partners to work with the government of Tanzania to realize this. Because we have a number of lessons from Kenya, from Ghana. Ghana started very well, but now they're a bit struggling. Their financing framework was not very much clear when they started. Even the UK. So we need to take stock of all these lessons and see what works better for us, try to contextualize going forward. So for me, we need to keep on investing in these type of initiatives, which targets the poor, because 28, I think if not 26% of Tanzanians are living in abject poverty. That's a huge number. It translates to 14 million people. So if 14 million people means we need to have very good strategies. We need to make sure Care International expand their coverage. This is what we want to hear from Masako and the others, the Prudence. No, 2 regions not enough. Let us go beyond 2 regions. And then the ICHF, the informal sector, should be at the core of this business. We have the formal sector, we have no other options, but the informal sector, it requires us to put more effort to move. Thank you.
Thanks. I totally agree. We need to encourage the likes of VSLA. So last question to Tarimo. Initially, Lelo alisema kwamba moja kati ya sababu ilifanya wakashindwa ni kwa sababu vikundi vilikuwa vinaleta udanganyifu. Wanaingia watu ambao sio wana vikundi, lakini nia yao ni kupata tu ile bima. Hivi vikundi vina udhibiti kiasi gani wa kuzuia udanganyifu wa watu kama hao ambao wanaingia sababu tu wanahitaji akapata huduma za bima na sio mwanachama wa muda mrefu?
Asante. Kwanza niseme sijajua kama walifanya uchunguzi kiasi gani kubaini hilo, kwa sababu kwenye vikundi hivi vya kuweka na kukopa VSLA ni ngumu mwanachama kujiunga hata katikati tu ya mzunguko wa kawaida. Wanachama wanajisajili mwanzoni, kisha wanafanya utaratibu ambao kama alivyosema madam ni wiki 52. Baadaye wakishamaliza mzunguko, hata kama ni mtu mpya anaingia, watamjadili upya, watamfanyia mapendekezo. Hata kama ni mwanachama alikuwa msumbufu, wanamjadili na wanamuondoa. Kama kuna kwa mfano katika kanda ambayo nilifanya, katika vikundi hivi ambavyo nilijaribu kuongea nao na wakajiunga na huu mpango, vikundi kama 9 walijiunga na hawakupata huduma, lakini waliridhika kabisa na walilipa kwa pamoja, wala hawakulipa mmoja mmoja, walikaa wakajadili wakalipa kwa pamoja. Kwa hiyo kama kuna mahali pengine ambapo kulitokea udanganyifu wa kujiunga, ni namna tu ya kuweza kupewa elimu. Na nafikiri pia kwa kushirikiana wadau kama Care ambao wanasimamia vikundi, NHF na maendeleo ya jamii, wakikutana kwa pamoja wakiwapa elimu, udanganyifu kama huu ambao unaweza kutokea, kama ilitokea basi unaweza kuondoka kabisa. Lakini wanachama wengi ni waaminifu na wana mfumo maalum kabisa wa kikatiba ambao kujiunga mtu ambaye kikundi kilishaanza ni ngumu sana.
Asante sana. I think this also solidifies the point of Dr. Ntuli that these teams has to come together. So now I open the floor to the audience. I still have 17 minutes, so if you can ask your question or a comment in 1 minute, maximum 90 minutes. I have 1, 2, 3 from this side and 1 from this side. So we start here. You can use.
Thank you, Chairman. My name is Dr. Sam Kikaro. I'm from Pathfinder. One of the low-hanging fruit, which was not mentioned, is the topic which we are discussing, the VSLA. I would like to call upon our NHIF guys to think again about how do we optimize the opportunity of the VSLA, which are down in the villages, where some VSLA, they have a lot of money. They have over 60 million shillings. How do we put some regulations to ensure that these VSLA, which have large capital, to be treated as other corporates, so that members from the VSLA with, let's say, over 50 million, you have 20 members, to have mandatory NHIF for all members, because they just lack that knowledge and sensitization about the importance of health insurance for their members. We may also think about the corporate social responsibilities in places where, for example, you have districts or regions where there are national parks, or, for example, we are supporting projects in Katavi and Kigoma regions. We had villages which were supported through the funds from the carbon credits. They got insured. All 11 villages, people received the health insurance, but it was ICHF. So why don't we use that? A lot of money, it's billions of money which they are getting from carbon credit. Why they didn't opt for NHIF? They just offered ICHF. So we may explore also the opportunity of the mining sector and the other places where they can do health insurance as part of their corporate social responsibility. Thank you.
Thank you very much for the presentation. Yeah, I just have to ask one question from the group. You are talking of groups, but universal health coverage says leaving no one behind. And who are you going to leave behind? The stunted, the poorest, yeah? The one who eats half a meal. So when you deal with the group, you can get a lot of money. But if you are not going to leave anyone behind, we would like to even go down there. So can you please share us the scientific, right, paper, so that I can also reproduce it in my village. But it must leave no one behind for universal health coverage. And finally, the countries that are doing best in the world in universal health coverage, they do not charge people. They have no out-of-pocket expenses. It's all taken care by the government. There are about 20 countries.
Thank you. The lady with a green and then behind her.
Good afternoon. So I have a question. First, I'm impressed with the partnership between CARE and NHIF. But then if I figure it correctly, is that initially the group was an economic group, then NHIF came in. But then now we see there's a lot of initiatives whereby there are community-based patient groups, either it's NCDs or it's HIV or other diseases, name it. So I'm just wondering, can CARE come into these groups and integrate their activities as secondary, not primarily? Thank you.
Very good question, or the other ways can also be the question. The lady there, yes, and then two behind, then we'll allow the response.
Thank you, presenters, and I have two questions. The first one is for NHIF. I think it's high time now you have to start thinking about these packages and introduce issues like lipia kidogo kidogo, because at the moment people who are from corporate, they can pay monthly, and if you want to pay for individual, then you have to pay like a home amount. So I think lipia kidogo kidogo package will help to include, you know, people who earn, kidogo. And the second one ni kwa mwalimu. Niwapongeze CARE na mwalimu ametupa summary nzuri ya kazi ambazo wanafanya, lakini nipenda kujua zaidi hivi vikundi vya kina mama. Bahati nzuri saa hizi kina mama tukiitana hapa wote, sijui kama kuna ambaye hayuko kwenye kikoba. Huwa tunakuwa na vikoba, it's official. Ukiwa mama lazima uwe na kikoba. So tukienda kwa mwalimu kwa sababu amekuwa akitoa mafunzo, nipenda kujua kwa sababu unakuwa na vikundi vingi. Je, hawa kina mama mnatumia njia gani? Je, kuna mfumo wote wa kidigitali ambao unawasaidia kuwakusanya pamoja na kuwapa mafunzo, lakini baada ya mafunzo hizi pesa zao wanazitunza vipi? Sababu tunajua cases nyingi sana kwa kina mama, mara begi linapotea, mara tunavunja kikoba, hela hakuna. So those kind of issues ningependa kujua mwalimu, kwa sababu upo kwenye field, utuambie ni namna gani basi mnatumia kuwapata kina mama lakini pia kutunza fedha zao. Kingine pia nipata kujua kama mnatumia hizi bima za tunaziita za mkono wa pole kutoka benki mbalimbali. Kina mama wengi ambao tuko kwenye vikoba siku hizi ni kitu ambacho ni mandatory. Nikishakuwa 15 mnachukua kadi zenu za NIDA, then mwenyekiti unaenda unapeleka benki, alafu baada ya hapo mnapata ule mkono wa pole. Nitaka kujua hayo tu, asante.
Asante.
Naitwa Ansia Kipiliango, natoka Inspire Consultant, ni digital health consultant.
Okay, lady with a black, then two behind, then you will allow. Please be brief.
Yeah, thank you. My name is Agnes from FHI 360 EPIC. So I just want to ask NHIF, or rather challenging you, like what is innovation plan you have in place? Just echoing my brother there who spoke about this VSLA. We have the registered group at the district council. It's easy for you to access them and advocate for them to join the NHIF. But another thing that, as you call it, a hanging fruit, we still have the schools. You can just try to be innovative and reach out to the schools, the college and stuff like that to advocate for them to ensure that the children they're having and stuff, that, they join the health insurance. Thanks.
Okay, two behind. There's the last one here, and the lady in front of her.
Okay, thank you, moderator, for this opportunity. My name is Anodi Kaihura from Tanzania Sanity. So I'm happy to join this session. My submission is VSLAs are just examples of social community groups that we have in our community that we can leverage on to advance the agenda of universal coverage and insurance. But we have so many social groups that we can leverage on to tap into potential. For example, I come from the farmers community. To my home village, they have social cooperative unions where they sell their coffees and other.
Please be brief.
Those are very important social structures that we have in place that we can leverage on to make sure that they have health insurance so that we can increase the pull-up. Another thing is to change the mindset of the people. You know, we need to go to localize our language when we talk about health insurance. And let me make this clear in Swahili. Ukienda kijijini kwetu ukamwambia bibi yangu tunataka 30,000 au 100,000 kwa ajili ya bima, hata ukupa anakuambia. Lakini ukimwambia tunahitaji debe moja la kahawa tuweze kukupa health insurance, atakupa na kesho atapata hiyo health insurance, because that is a value. So kama na msukuma na ng'ombe ukule usukumani kwetu, atakupa ng'ombe. Those minor properties ambazo zipo ambazo unaweza kazi value ukaweza mtu akaweza ku achieve that health insurance, that will save, because the aim is to save the purpose.
Thank you so much. Last one.
Thank you so much for the nice discussion so far. My question is directed to the NHIF. Have you considered the role of actuaries in managing the risk? I think one of the key things I picked out from the discussion was the risk of anti-selection. I think a good example, you said there was a ushirika wa afya for farmers ambao walikuwa kama 200,000 lakini 500 tu ndo walijoin. So that's a typical anti-selection risk. So are you using actuaries in addressing this risk, and how are you going about that?
Thank you. So I'll start with Tarimo. Una majibu yoyote ambayo unataka kujibu kutokana na maswali yaliyoulizwa?
Asante. Kunijibu swali kimama aliuliza kwamba namna gani ambavyo walimu wanaweza kuvifikia hivi vikundi na jinsi pia ambavyo wanaweza kutumia kutunza kumbukumbu na pia kunufaika na huduma za kibenki. Kwanza niseme kwamba shirika la KEA ni kati ya mashirika ambayo yana mfumo mzuri sana katika usimamiaji wa vikundi vyake, na ndio maana kuna watu wa ngazi ya chini kama walimu ambao ni CBT, na pia kuna namna ambavyo wanaweza karipoti matatizo moja kwa moja kwenye care kwa muda mfupi, na care wako makini sana katika kuhakikisha kwamba walimu wale wanawapa mafunzo ya mara kwa mara ili kuweza kusimamia vikundi. Kwa hiyo usimamiaji wa vikundi ni rahisi sana, lakini pia wana kitu kinaitwa udurufishaji, ambapo mwalimu anawafunza wana vikundi wengine kwa ajili ya kuweza kusimamia vikundi. Kwa hiyo unakuta ni katibu wa kikundi au mwenyekiti, lakini anaweza kusimamia vikundi vizuri kama mwalimu hayupo. Lakini pia kwenye utunzaji wa kumbukumbu, care pia wamewaanzishia wana vikundi huduma ya chomoka, ambayo wana kikundi wanatunza kumbukumbu kwa mfumo wa kidigitali. Na hata mwana kikundi kama hajaenda kwenye kikundi, amepeleka share yake kwenye kikundi, akiwa nyumbani atatumiwa ujumbe kwamba share yake aliyopeleka leo ni kiasi fulani, na pia akatumia hata pia kile ambacho kimefanya kwenye kikundi. Kwa hiyo utoaji wa huduma kwa njia ya kutunza kumbukumbu kwa njia kwa vikundi vya VSLA ni mfumo rahisi na wa kidigitali kwa sasa. Lakini pia kuhusu nufaika namna ambavyo wanatunza fedha zao, mfumo wa vikundi wa kina mama, mnajua fedha zinazunguka. Mnaweka share yenu kisha mnakopeshana, mfumo unaendelea kuzunguka. Mnakuwa na thamani ya fedha, lakini fedha zipo kwa watu. Ikifika wiki 40 ambayo ni mwezi wa 9, fedha zinaanza kurejea katika kikundi. Zinapoanza kurejea, wakati fulani kulikuwa na hali ya tarishi ya kifedha kwa wanakikundi ambao wanatunza zile fedha. Wakati zamani tulikuwa tunatumia masanduku, lakini sasa hatumii hivyo. Kia baadaye walikuja na mpango wa link up ambao wanachama kikundi kinafunguliwa akaunti ambazo hazina makato, wanatunza fedha zao kwa miezi mitatu, kisha wanazichukua baada ya miezi mitatu, wanagawana kama kawaida. Na katika utunzaji wa fedha wananufaika kwa sababu akaunti zenyewe pia hazina makato, wanakatwa tu pale wanapotoa, lakini kwenye utunzaji huo akaunti zile za link up hazina makato. Kwa hiyo utunzaji wa fedha ni rahisi sana na wananufaika sana.
Swali moja la haraka jibu ndani ya sekunde 30. Imeshawahi kutokea mwanachama akashindwa kulipa kwa sababu aliugua akatumia ile hela yake ya mkopo kwenda kutibiwa?
Ni kweli. Baadhi ya wanachama katika vikundi vyetu walishawahi kukopa kwa asilimia kubwa, wala sio mmoja wawili. Walishawahi kukopa kwa ajili ya kwenda kufanyia matibabu na wakashindwa kurejesha pale ambapo kikundi kinavunja. Ishatokea mara nyingi na ni hasara kwa kikundi kwa sababu watapaswa kumvumilia kwa muda. Na ndio maana hata vile vikundi ambavyo viliamua kufanya bima ni baada ya kuona kwamba wanaondoa hali ya hatarishi ya kifedha, kwa sababu wanapokuwa na bima akiumwa hatumii tena fedha ya kikundi.
Asante sana. Christine, you have anything to respond?
Yes, thank you. I wanted to respond kwa dada nani alivaa green.
One minute.
Yeah, kwa hiyo, she talked about that our relationship with NHIF kwa hizi groups kuanza kama economic groups. Yes, we started as economic groups because we are working with a marginalized community who don't have capital. Na hawezi ku access his services because they are lacking capital and they are living far away from Dar es Salaam. So that's why we mobilize them first to have such kind of capital, but also having the place where they can access loan, but also using social fund, na ndipo waende beyond kwenye ku access hiyo as insurance. So currently, yes, we see that it's potential for them, not only saving. So currently we have been adding another innovation within this kind of VSLA. We have, for example, collective investment. So along with saving, social fund, they are also doing collective investment where specifically they can discuss. We want to invest in maybe such kind of business, maybe nursery school or tree nursery or a shop like that. So they can save collectively. And when they meet, they can have 2,000 or like that. So I see the potentials of using Christine. That kind of opportunity.
Just a quick question, because now I'm advocate for non-communicable diseases. Are you planning to integrate non-communicable diseases program within the VSLA? Yes or no?
Yes, because we see that this is because it's an entry point. You can integrate whatever you want.
Okay, thank
so
you.
For currently, we are
much.
integrating conservation work within that. We are integrating the, as I mentioned, the agri fund within that. We can also integrate the health insurance fund within those kind of village saving and loan association.
Thank you. Dr. Ntuli, anything to respond in 1 minute?
I wanted to caution my colleague that when you integrate, you need to be careful. Otherwise, you collapse the funding. Yeah, integration, sometimes if you expand very fast, then you may end up killing everything, killing even the vision. So I wanted to be a bit cautious about that. Maybe to respond to what Sam asked on carbon credit facility. Now, it's not about people joining NHIF and leaving a CHIF. No. With the current draft bill, we want people to be in one of any. You can be in the private, you can be under NHIF, you can be under CHF. All what we want is universal health insurance. If everyone is covered with it, then the solidarity principle works and everything goes well. A quick one to Dr. Swai. Leaving no one behind doesn't mean that we should not pursue these approaches. We should. Why not? These small groups is also the way to achieving that big dream of ours, of health for all and leaving no one behind. So let us take it as one of the initiatives. Slowly we'll be able to cover the entire population. But on the community disease-based groups, no, we cannot encourage this one because that will be an adverse selection. You'll be selecting only the sick to join into the scheme, and that will kill the fund. For us to be able to have a viable fund, sustainable one, the health and the sick, the rich and the poor should be on the same pool. And this is what we call the pooling mechanism. You pool the risk together, you pool the finances together, and this ensures the sustainability of the fund. So I thought maybe I needed to add those two. But on the Arnold, what you have said, we tried that one. In Bai and Singida, we had the Kuku initiative, Kuku Moja and the other thing, and that worked pretty well. So we invite those type of innovations which sounds and resonates well with the communities. And in so doing, surely we'll be able to increase the coverage of insurance in the country. Thank you.
Thank you very much. Dr. Makwani, 1 minute. I guess as Dr. Ntuli said, the question should be how we can strengthen ICHF. So Dr. Makwani, 1 minute.
Of course, not boring. We shouldn't get bored here. I was joking here saying that I think we need to start mazizi ya ng'ombe, mazizi ya kuku, so that it looks pretty well and easier to mobilize the resources. That's first thing. And then the other thing is no shoe that fits to everyone. Kwa hiyo Tanzania haiwezi kuwa Nigeria, Tanzania can't be Rwanda, Tanzania can't be UK. Every country has its own ways of solving problem, but the approach must be the same. So I think the way to go here, I call upon this group that we need support, we need to advocate for having an instrument, and that is National Health Insurance Bill.
Thank you very much. Save the best at last. So Lelo, if you can use 1 minute to finalize.
7 questions here, but I'll combine them. The first one was a proposal, NHF thinking again to onboard the groups. We are ready to partner with CARE International. We are ready to partner and to explore this opportunity to register these groups. We believe in group enrollment, of course. So we believe if they come massively, we can even reduce the premiums. So we are ready to cooperate with them. Then about groups like students, we have student health insurance, 50,400 per year, from kindergarten to first degree. So that's a sufficient group. Now we have, for university, we have 75,000 students as members of NHIF, and still onboarding more. Role of actuaries, yes, we have actuary department. We also have external actuary who conducts the actuarial evaluation of the fund. And this is discontinuation of the products is because of the advice from these actuaries. So we use them in managing our products. Finally, on way forward now, we should all advocate for compulsory healthy insurance, because that's the way to go. No way out. We need to use that one. Thank you very much.
Asante sana, naomba makofi kwa panelists. To close out our event, I invite Program Director, Aika, from CARE.
Thank you very much. Good afternoon, everyone. I just want to thank the panelists. In my closing remarks, I think I shouldn't add anything. There is a lot that have been said here. And what we are saying, we are not really late. Dr. Makwan, we are not late. We've seen there's a number of opportunities. There is a lot of pathway, including technology, policies, and what we are saying, and thank you, NHIF, just to tell the audience here, we are ready to partner with NHIF through the platform of VSLA. And as we continue doing our programming and expanding towards the southern Tanzania, as well as the western regions, we are ready to ensure that we start using the platform, the VSLA platform, and achieve the agenda that we want. So I would like to thank you very much and have a good afternoon. Another round of applause to our panelists. Thank you.
Excuse me, please, the following people should follow me. Dr. Ntuli, Dr. Marwa, Dr. Makuani, Bernard Konga, Dr. Rashid Maulid, and Dr. Mshana. The rest should go at Kilimanjaro. Third floor.